information about my previous work. So I will talk about neuromuscular ultrasound. These are my disclosures. And the first, as you all know, that traditionally there were clinical examination and electrodiagnostic that were the most important. But we know that we have several limitations for electrodiagnostic studies. The main limitation is probably that we cannot establish the etiology of the lesion. Another limitation is also that most of these studies are rather painful. Therefore, there is some space also for other things. And as was mentioned also before, in this session, neuromuscular ultrasound is one possibility. You can, of course, use MRI, but MRI is more expensive. We also heard today that some people might be claustrophobic, cannot get in. And also the technicians that are doing MRIs usually don't know what is our question, what is our problem, and you will not be surprised to get the study done, but without the real answer to the problem. So with development of the technique, we are catching up with the central neurology, and now we also have a morphological tool that can be used in clinical practice. So these are the machines and the probe. The most useful is actually this one. This is a linear probe with a usually high frequency. It should be for examination of nerve more than 13, 14 megahertz. So the whole point of these advancements is use of piezoelectric elements. These are those small dots here. So they are able to change electricity into mechanical movement, into the sound, and then way also back, enabling us to produce the picture. So here are individual piezoelectric elements, and about the second dimension is we are told by delay when the response comes from the tissue. Therefore, this is the way how the picture is built that we see. So the neuromuscular ultrasound today is very capable, able to see very small structures, very good to see also vascular lesions using Doppler. And it's a very good thing also to combine it with electrodiagnostics. As I said, we will have a problem, we will look at the patient, but we will not know what is the answer, or will not be able to stimulate or in other way to find out what is the problem. And then if we have a linear probe and the appropriate machine, then we can do it just by doing this kind of studies. So we can examine particularly nerves and muscles in cross-sectional. So this is the cross-sectional view of the nerve, and this is longitudinal view of the nerve. And here we also have cross-sectional view of the muscle and of the nerve. Very important point is anisotropy. So one important thing is that we really put the probe perpendicular to the tissue, to the nerve. Otherwise, we'll not get a great picture. And also our measurements will be inaccurate. So it is actually this response that is important. If we don't put it perpendicularly, we will not see the picture. When we examine the patient, we start with putting the probe at typical positions. There is good literature on that can instruct you where to put the probe and how to proceed with the study. How can we recognize the nerves? So they have characteristic appearance, both looking in short view and in long views. So this is so-called honeycomb appearance and fibrillary appearance in the long way. One point which is very important is also already mentioned, anisotropy. So when we change the position of the probe, the tendons will get black and white very much, but the nerve will stay much more the same. So what is the response of the nerve to pathology? The main response of the nerve to pathology is to get thicker. This will happen in compressions, entrapments, trauma tumors, demyelination. There is an exception. If you have very severe entrapment, you might have actually the thin nerve. We can also have a look at different fascicles if they are thickened. And we can also, as mentioned before, look at echogenicity. Usually when we have inflammation and edema, the nerve will be more black. That means hypoechogenic. But if it is changed by fibrosis, it will become more white. So then we can have different protocols how to optimize our image. So first we have to have a good machine, correct probe, use sufficient gel, then turn the knobs on our machine appropriately and start to examine. So usually we would examine the whole nerve, which is a good thing. So we can see if there is any pathology also on sides that cannot be appropriately assessed by electrodiagnostic studies. And the most important parameter, as I mentioned, that the thickening of the nerve is the most important mechanism of pathology in the nerve. Then measurements of cross-sectional area is the most important. It's like amplitude on nerve conduction studies. And as I mentioned, we look at the nerve, see where is the thickest, and usually measure them. Or maybe also see where is the thinnest, because that may be the place of entrapment of the nerve. So of course, this is not a magic bullet. Neuromuscular ultrasound also have its limitations. So it is a morphological study. It's not a functional. And therefore, this is a very good complement to the functional studies as electrodiagnostic studies. Another problem is that it's not good to differentiate neuropraxia from axonotmesis. And this is exactly what nerve conduction studies are the best. Of course, we have some problems with proximal lesions, and also it takes some time to develop. So now I will just briefly talk about focal neuropathies. Here I'd just like to point out two different things that we have with focal neuropathies. So we have to make a distinction between external compression and entrapment. And in cases of external compression, the nerve will just thicken on ultrasound. On entrapment, you can also find the thinning of that point. So just to tell you about which you can imagine, so carpal tunnel syndrome, true cubital tunnel syndrome, Guénin's canal syndrome, supinator syndrome, etc. These are the entrapments. On the other side, we have compressions, which are ulnar neuropathy at the retrocondylar groove, then satellite palsy, superficial radial in distal forearm, and so on. This is very important point because this will affect how we will treat the patient. So the most important focal neuropathy, of course, is median nerve entrapment at the wrist. Usually we measure cross-sectional area at the wrist and in forearm. In most of the cases, the measurement at the wrist will be all that we need. We compare it with reference values, and that's our result. So usually it can take just to say 10, 20 seconds to do that. So about sensitivity and specificity, it might be slightly less sensitive and specific, but that very much depends on what patients we see. If we would have seeing only patients with very severe carpal tunnel, ultrasound will be actually more sensitive and specific, because with very severe carpal tunnel syndrome, you might not have the responses electrodiagnostically. So apart from cross-sectional area measurements, you can also have lots of different other parameters which can be used, but at the time it's not, I mean, you can take them as complementary, and I think there should be more studies to find their real utility. So what is my suggestion about using? So first thing, we see a lot of, at our lab, we see about 4,000 or 5,000 carpal tunnels per year. We think that many of them we don't need to see, because the first thing, if you have a patient with clinically suspected carpal tunnel, you can just start with conservative treatment. And if this fails, or if the patient has very severe lesion, then you can confirm it either electrodiagnostically or using ultrasound. Other indications, for example, I mentioned before, if you have absent electrodiagnostic responses, then very useful to see after surgery, in case of persistent or new appearance of symptoms, for injections and other things. So this is a case of a lady that with failed surgery, and we were able to demonstrate that there is compression, external compression, due to fibrous tissue that developed at her wrist. So I'll talk about ulnar neuropathies at the elbow. This is a neuropathy I'm very much interested in. We actually demonstrated that there are two neuropathies. One which is, so this is proximal and distal, medial epicondyle. This is proximal 2, 4, 6 centimeters, and these are distal. And one of those will be found here and here. And we can find the thickening of the nerve at 2 centimeters proximal, and here conduction block and reduced conduction velocity. So we actually localize the lesion, diagnose the lesion proximal to the medial epicondyle. And we believe this is due to external compression. And then we have another type, which is 2 to 3 centimeters distal to the medial epicondyle, which is here. So this is under humero-ulnar aponeurosis. Again, we will have thickening proximal to this, thinning of the nerve due to external compression here, reduced nerve conduction studies very much here, not so much of the block. So we have electrodiagnostic and morphological localization. And we will sum up these two. So here, actually, ulnar neuropathy at the elbow, it's not neuropathy. There are two neuropathies with different mechanisms, different populations affected, different arms affected, different morphological, and they need different treatment. These patients, just, we have to say, don't put your arm while using your computer on the desk, and these patients need to go to the surgeon. So we also demonstrated increased changes in cross-sectional area by severity of the lesion. Sensitivity also slightly lower in general for neuromuscular ultrasound, also in this condition. Precise localization is the same, but still it's very helpful to have very good localization. Our surgeons can do just small incisions. It's an outpatient procedure, so this helps. So from our work, we can also find the suggestion that if you have a severe neuropathy, maybe try first a neuromuscular ultrasound, because it might be that you will not get the responses. And on the other side, if you have very mild lesion, then it's maybe better, or if you are not that, I mean, the clinical diagnosis is in electrodiagnosis is not that clear, then maybe, I mean, first to start with electrodiagnostics. So these are two women, just to illustrate how it can be helpful in clinical practice. At the same age, the same problems, they were not able to extend their fingers. They have the same electrodiagnostic studies, normal sensor nerve conductions, low amplitude CMAPs, and different ultrasound picture. So the left lady had thickening in the radial canal, and the second one had change in area of the supinator canal. And of course, the treatment was different. The left lady was treated with IVIG because this was supposed to be NMN, and the right one was sent to a surgeon. Very useful also in trauma, particularly to find out is the nerve in continuity or not. For example, this gentleman had a fracture of the humerus. We found the discontinuity of his nerves with nerve stems, and we did not need to wait for months. He could be sent to a surgeon and complete the surgery immediately. Similar for nerve tumors. Before using this technique, we were not able in our lab to make any diagnosis of those. Now we have quite some of them. This is one case of 17-year-old girl. She had foot drop at the age of 8. She was not able to dorsiflex and invert her foot. So she had absent fibular CMAP and snaps, reduced tibial snaps. So this puts the lesion to the sciatic nerve, and we were actually able to demonstrate the tumor. This is on cross-sectional and longitudinal, and this is MRI confirmation in her thigh. Another one, interesting young man with similar problem, tibial nerve affected, and we were able to demonstrate a large lesion in popliteal fossa, which we should not do it electrodiagnostically, and this was a ganglion cyst, again, needs surgery. Polyneuropathies are more and more important in this. You know that there is still a lot to be improved here, and there are many problems. I mean, differentiation, Guillain-Barré from acute onset CIDP, MMN, ALS, and so on, and we can map the changes. We can use different protocols. So we have now a lot of experience with that, and we can tell what will be typical findings in different polyneuropathies. Different polyneuropathies have different thickenings of the nerve. So the most typical is CMT1A, which have the thickest nerve, uniform thickening of the nerves. And there are also different scores that can be used for this. So and we also learned from these scores that CMT1 have uniform and very severe increase in cross-sectional area. CIDP will have less of increase, which will be non-uniform. MMN and Lewis Sumner regional, segmental increase in cross-sectional area, and so on. So this is a man with typical CMT1A, and we were able to find both electrodiagnostic and ultrasonographic changes. He could be diagnosed directly genetically after that. So very important, and not to forget also muscle ultrasound. It started already in 1980s, and this time it's not that popular yet because, as we said, cross-sectional area is the most robust parameter for nerve ultrasound, and this is not too difficult to measure. On the other side, the problem with muscle ultrasound is that the most important is echogenicity of the muscle because of changes with fibrous tissue, fat, and so on. And but the problem is that if you change the machine, if you turn your knobs, then everything, your result will change. So and many other factors also affect muscle ultrasound, which mean particularly that you need different reference values for different ages, for different muscles, etc. So a lot of work to be done. So you can use this semi-quantitatively Hackett grading scale, which is not very precise, very reliable. So quantification is actually much better. But as I said, there are some technical problems. But now with some equipment, we will be probably able to get also the reproducible information about this in near future. Then we'll get the Z-scores, which will tell us how many standard deviations this muscle is separated from a normal one. We can also actually, we have some distinctive features that can differentiate between myopathic, inflammatory, and neurogenic muscle. And just to conclude, so neuromuscular ultrasound is valid, accurate, it affects diagnosis and treatment plan in patients with neuropathies and myopathies. It's most useful for demonstration of location, pattern, and severity of nerve swelling. Electrodiagnostic studies are preferred as initial investigations, mainly in mild, demyelinating, focal neuropathies, and neuromuscular ultrasound is better in severe axonal lesions. So they are most useful to answer specific questions unresolved by neurological examination and electrodiagnostic studies. The muscle ultrasound at the moment is less popular, but we believe that in several years it will be as useful as nerve ultrasound is. Thank you very much.